This webinar is a first in a series of 6. The topic is Pediatric Brain Injury 101, and it's presented by Ann Mosner from the Mayo Clinic up in Rochester, Minnesota. This webinar is supported by the Iowa Department of Public Health in partnership with the Brain Injury Alliance of Iowa and the Governor's Advisory Council on Brain Injuries. And this is actually supported through a grant from the Health Resources and Services Administration for traumatic brain injury implementation. And now I am going to say thank you to Ann for being our presenter today, and I'm going to turn it over to her.
All right, good afternoon, everyone. As was mentioned, my name is Ann Mosner, and I'm going to be presenting for roughly an hour this afternoon. I was asked to speak on pediatric brain injury and to make some introductory remarks about this condition, some of the common sequelae, and some of the treatment options that are available. The themes that I'll be speaking on today, we have learned a lot about traumatic brain injury over time, both at Mayo Clinic and around the United States. And there's a lot of evidence that coordinated care of the acute phase of the injury as well as the chronic phase by specialized providers does make a difference in long-term outcome after brain injury, as well as hanging on to and following individuals that have TBI, linking rehabilitation goals with school and vocational and community goals is also important. Early intervention seems to be very vital to short and long-term outcome after pediatric traumatic brain injury. You'll hear me speak about that several times. We have a large focus on involvement of and education of families as key support individuals in the patient's life. Really return to home, friends, school, family drives a lot of rehabilitation and medical care for people with TBI is an important component. I'll be talking a little bit about hope. It's certainly always okay to have hope for ongoing recovery and good outcomes after TBI. And you'll hear me talk quite a bit towards the end about mild traumatic brain injury and the fact that most people with mild TBI actually recover quite well. Just one quick slide on TBI in the United States. There are about 1.5 million, give or take, depending on who is running the data, injuries per year in the United States, with a good number of people hospitalized annually. TBI is the leading cause of death and disability among children and young adults. There are frequent injuries occurring every 23 seconds or so. Each year, about 90,000 people experience long-term disability following TBI, and the risk of TBI is highest among young adults.
Ann?
Yes.
This is Megan. We're not seeing your screen, and so I'm going to give the presenter back to you, and then you're going to need to share your screen with us so we can see your slides.
Okay, thank you.
Yep.
Yeah, Megan?
Yes.
It's still not working. I wonder, yeah, it does say, I'm only seeing about a quarter of the screen here.
Okay.
Do you?
Can you open up your viewer anymore?
I can.
I can see yours.
Okay, let me.
We can see your full slides.
Okay, back now. Okay, there we go. Does that allow everyone to see?
Yep, we can see the whole thing. Thank you.
Okay, wonderful. Each year, I was saying 80,000 to 90,000 people experience some long-term disability following TBI. The risk is highest among adolescents, young adults, and those greater than 75. There's a lot of evidence that once you have one traumatic brain injury, it increases the risk of your second, third, and so on, which is one of the reasons we stress prevention. And in the world of traumatic brain injury epidemiology, Most injuries are actually mild traumatic brain injury, which is also known as concussion. This is just a slide on prevalence, which means if I take a snapshot of everybody currently living in a population with a specific diagnosis or condition, you'll see that traumatic brain injury and the number of individuals that have been affected, the numbers are very large for this particular injury. Just a little bit about brain injury at Mayo, just to put it in perspective who I am in the center that I work in. And Mayo represents other large level 1 trauma centers around the United States, but TBI is very common. Most big hospitals are level 1 or 2 trauma centers. We receive a lot of trauma patients. In both Minnesota and Iowa, there are trauma registries which track the numbers of TBI and spinal cord injury patients that are incurred in each state. Mayo is CARF certified in pediatric rehabilitation. We, like other centers, have an entire specialized team of physiatrists, which is another word for a rehabilitation physician. Neuropsychologists, the PT/OT, speech therapists are very important, social work, vocational services, and we have rehabilitation nurses involved in our program as well. Most programs like ours have school, job, community reentry services, and we have both research and education programs up in Rochester, and then, like many places around the country, a lot of emphasis on sports concussion and injuries at this point in time, and I'll talk more about that in a little while. What brought me here, or what is my background? I have been at Mayo Clinic for 27 years in adult and pediatric brain rehabilitation. I currently work as an advanced practice nurse. I see pediatric outpatients age 14 and above. Formerly worked in the inpatient setting and saw TBI patients of all ages. I do a lot of work with sports medicine, and in fact was just at a meeting yesterday with some new guidelines coming out about treating sports concussion injuries. I've often, and several of us at Mayo, actually go out into the schools of children with traumatic brain injury, whether it's a concussive or a mild TBI or more serious injury. Mayo's been very gracious about letting us go right out into schools and be part of the school IEP and 504 teams and to educate teachers, coaches. So you'll hear me talk a little bit about that later. Also, part of my position at Mayo is to be a long-term point of contact for children with TBI. And then I happen to coordinate and am a co-investigator in several research studies at Mayo Clinic as well. So types of brain injury, let me just start with a little terminology. When I first started working in the field, TBI was referred to as closed head injury. Well, it's really an injury to the brain that we're concerned about versus the head and the skull. And so a decade, 10 to 15 years ago, the terminology turned into traumatic brain injury, which really involves an external force to the brain. That's a fairly well-accepted diagnosis or term around the country. But TBI is one type of acquired brain injury, which just means this is an injury that was acquired sometime after birth. There are other types of acquired brain injury, and in our practices, most practices around the country that do pediatric brain rehab, we really do see people with TBI, stroke, brain tumors, anoxic injury or lack of oxygen injury from near drownings, for example, infections, encephalitis, meningitis, and then some, not as prevalent in the pediatric population, but some patients with aneurysms, or AVMs, which are unusual formations in the arteries and the veins that are in the brain. So those are the types of brain injury that we treat. Now, I'll be talking primarily about traumatic brain injury, but please understand that that does include our treatment and approach is the same no matter how the brain injury occurred. A little bit about injury severity. You'll hear a lot from hospital providers, and you'll see online that TBI tends to be broken down into mild, moderate, or severe. The terminology is changing a little bit moving forward. There's a lot of confusion about this ranking of severity of injury, but it's the best system that's around now. Mayo is making an effort to to classify injuries a little differently, at least for research purposes. But for our discussion, we're going to put the injuries into two categories, one being mild and then moderate to severe are going to be discussed separately. And basically, we categorize based on CT scan, something called the Glasgow Coma scale, which is a rating scale used at the time of injury, which looks at the patient's ability to talk, speak, follow directions, open their eyes, those sorts of things. One of the things we pay attention to is how long was someone unconscious, and then the duration of their post-traumatic amnesia, and by that I mean confusion. So amnesia, when it comes to TBI, doesn't necessarily mean people who cannot remember their past, confusion about their own name and who they are and where they came from, sort of like you see in the movies. Amnesia refers to, in the post-traumatic recovery period, confusion. People just being confused about what happened yesterday, having short-term memory problems, kind of from the accident forward. So how long someone is quite confused about their injury is one of the classifying factors we look at. So when we're talking about mild TBI today, also known as concussion, those individuals have negative CT scan. Actually, my screen is blocked out on the right side. Let me move that. Okay, so I can see. Negative CT scan, a loss of consciousness less than an hour, Glasgow Coma in the 13 to 15 range, which is approaching 15 as a normal exam, and post-traumatic amnesia, so the person is confused less than a day. When you get into moderate to severe, we're looking at positive CT scan. So when someone has scanned their brain, there is bruising or bleeding or some evidence of organic change, or loss of consciousness greater than an hour, a Glasgow Coma score that's in the lower range, meaning the patient was having more difficulty speaking, opening their eyes, following commands, or confusion greater than 1 day. Now again, 75% plus, some reports will say 90%, 85 to 90% of injuries are actually in the mild category. So a word of caution about this severity discussion, and that is initial injury severity doesn't always correlate exactly with later severity of symptoms or with long-term outcome. And by that I mean somebody could have a so-called mild TBI based on these criteria when they come into the emergency room. But that doesn't mean they're going to have a mild outcome or that their symptoms over the long haul are going to be mild. The reverse is true. If someone has a severe traumatic brain injury, it is not always true that their residuals will be severe. There's a lot of crossover, so we try to educate patients and families on the front end that because this is your initial injury severity, that's all we're classifying. Time will tell how the symptoms progress and subside over time. So let's start with moderate to severe traumatic brain injury. In our center, like most centers around the United States, if you have a moderate to severe traumatic brain injury, you're going to go into a level 1 or 2 trauma center where we have specialized treatment teams, coordinated care, usually a broad range of physical, cognitive, emotional, behavioral, language residuals are possible with this type of injury. Most patients are going to have a full complement of therapies or at least an evaluation for therapy. Many children with moderate to severe TBI see a rehabilitation physician and or therapist on the hospital floor, and or their residuals are severe enough that they go over to an inpatient rehab unit. That's much more common than it is in mild traumatic brain injury. Many children with moderate to severe TBI have weeks to months of outpatient therapy. Many, I would say most, often need a 504 or an IEP plan initiated in the school setting. There's a lot of opportunity for family education and support, and long-term follow-up is more common. So I would say most systems, medical care systems, are set up to follow individuals with moderate to severe brain injury a little bit more than mild injury. In the moderate to severe TBI, some of the things that we do are, as far as nurses and some of the staff, ways we interact with the school, is we do school assemblies right away. I'll be presenting a case study in a little bit about an individual that we actually went out into the school right away to present information about her injury. We invite the school into hospital-based conferences. We attend IEP meetings, as I mentioned. We try to act as a liaison between the hospital and the school team. We do a lot of advocating for students to graduate on time. Should they be someone with a more severe injury, we try to be available to go right into schools, do staff training one-on-one via phone calls. Peer education is very important as well. Now I'm going to introduce a case study that I'll use throughout the presentation today. And this is a young woman named Frida, and I thank Frida and her family in advance for allowing me to share her story. They've been very gracious about that. Frida had a severe traumatic brain injury. She had a motorcycle accident in 2006 at the age of 15. She had posturing, which is a sign of a significant injury, with a lower Glasgow Coma score. She had some bruises in the front part of her brain. She had a subarachnoid hemorrhage, a subdural hemorrhage, which is describing where in her brain the blood is. Her primary injuries were open skull fractures. She had a jaw fracture, a collapsed lung, some spinal column fractures, and rib fractures. Secondary complications after she came into the hospital, she had a cerebral spinal fluid leak from the skull fractures. She ended up with some pneumonia, some blood pressure problems, weakness on her right side, a brachial plexopathy, which is sort of a nerve injury, and she had some spasticity difficulties in her legs. She did have a feeding tube placed and had a tracheotomy placed. She had the post-traumatic amnesia, and remember I indicated that that was sort of some confusion after her injury of 5 weeks, which is quite some bit of time. She spent about a month in the ICU, a month in the inpatient rehab unit, and about 6 months in outpatient rehabilitation. This is a picture of Frida in the ICU, and this is often children, teenagers with significant traumatic brain injury will often start in the ICU and have this sort of a picture of how things are looking. She's not on a ventilator, but you can see she's got a breathing or oxygen in place. She's got a cervical collar in place. She did have to have some spinal column surgeries. You can see on her right side that she's got some spasticity, and obviously she had a surgery as her head needed to be shaved. One of the reasons I share Frida's story is that her family, her friends, for being some teenagers under a lot of stress, created a Flat Frida project to try to help themselves cope with their injury, but to try to bring Frida along and support her and care for her in their special way while she was recovering from her serious traumatic brain injury. And I don't know if those of you out there know the book Flat Stanley, but this was a book written by a British author about a young boy who was flattened by a bookcase, and he mails himself around the world and has many adventures. So the friends created a Flat Frida, so I'll share some pictures with you just to break up the presentation and be part of the case study of some of the creative ways they brought Frida along. The first one, this is her dad and her pastor in the hospital with a picture of Flat Frida. Here's another picture of Frida in science class. She was a high school sophomore at the time of her injury, so you can begin to see that they brought her picture and they took her to school, to prom, to graduations, and again cared for her in this unique way. This is just a picture of myself and her dad doing an assembly at the school. And this is a picture of Flat Frida doing some homework. All right, I'm going to move into, I'm not going to spend much time on these next 4 slides because I think some of the information beyond these a few slides on anatomy are going to be more important. But the point will be that the brain has several different lobes. There's a left and a right side to the brain, and then several lobes within the brain anatomy. Really, understanding how these injuries occur and where is the most bruising, bleeding, stretching of nerve cells are going to help us usually predict what kind of difficulties people are going to have. Now, most people have a combination of a focal injury, meaning a particular part of the brain received a bruise or there was bleeding or damage in, like the left frontal portion of the brain. Many people, because of the forces involved in traumatic brain injury, the brain and the head sit on the spinal cord and the neck is involved, and there's a lot of whiplash motion, twisting and turning of the head. and a lot of that involves some whiplash-type movement. The brain really is soft like jello, and it bounces around on the inside of the skull with some impact. So many people not only have specific areas of bruising and bleeding, but they have widespread kind of straining and stretching of nerve cells. That's called a diffuse injury. The more localized damage is called a focal injury. So many patients have combined types of findings on their CT scan or MRI scan. Now, it's not always true that you can exactly predict how someone will turn out or what their residuals will be based on the neuroanatomy and where the damage is, but it is oftentimes very helpful and does predict with some accuracy. The front part of the brain is very oftenly injured because it's the furthest away from the neck. There's more force out there, and if you think about car accidents, falls, getting struck in the head, that often occurs in the front. As you can see, short attention span, difficulties with emotional and behavior changes. A lot of our motor function is located in the back part of the frontal lobe. Reasoning, judgment, some of the speech functions are located in the frontal lobe as well. Very commonly injured. Those are why we see those very common difficulties post-traumatic brain injury. The temporal lobes are on the sides of the brain. There's a lot of speech, receptive language function, taste and smell, hearing. A lot of memory function is in the temporal lobe, also very commonly injured in cases of traumatic brain injury. The parietal lobe a little less often, but we will definitely see plenty of folks who have parietal lobe injuries. A lot of difficulty with understanding where one's body is in space, perceptual difficulties when the parietal lobes are involved, and sensory processing can be affected as well. The occipital lobe is in the very back of the head, less commonly injured. Our ability to process visual information and understand form and depth perception is located in the occipital lobe. So when this is injured, you will see some difficulties in those areas. The cerebellum is on your picture is a little blue part on the bottom underside of the brain. And this is where reflexes, balance, muscle tone, and posture are located. So when there are cerebellar injuries, you will see some difficulties in those areas. Here's a picture of Flat Frida at a Mardi Gras party. Trina was an all-state track star in Minnesota, and so this is a picture of her with her track coaches in a classroom, and then also at a track meet. All right, so what do we look at in terms of recovery from traumatic brain injury? So when these parts of the brain are damaged, is it permanent? Is it temporary? How does the brain try to recover from such an injury? Again, I'm talking more about moderate to severe injury at this point in time. Well, it takes some time for the blood supply, the normal pressure in your brain, the swelling, the neurochemical system to settle down. So as those things start improving, like they do with any type of injury in the body, it takes some time for swelling and the normal chemistry and vascular system to improve. Then we often see an improvement in function. We really work hard on the acute care side in the hospital setting to minimize complications, because that can really prolong recovery and impair the short and long-term outcomes. So things like infections, preventing blood clots, getting patients moving as quickly as possible, making sure they're well ventilated, those sorts of things. Many people, as you can imagine, when they are in horrific accidents, have many fractures, internal injuries, other things besides their TBI. So a lot of time is spent on surgical repair of fractures, damaged spleens, kidneys. Sometimes there are surgeries to remove those organs, to repair those organs. So we really work hard to treat all those associated injuries and stabilize those as well as the brain. And then rehabilitation with a specialized team is important. Our rehabilitation therapists, as soon as it is deemed that this patient will survive their injury and they are able to tolerate any therapy whatsoever, the therapists are in the ICU, PT and OT, sometimes within 24 hours of their injury. 20 years ago, we waited until the patient was on the rehab unit, weeks to months after injury, before receiving services. Now therapy starts immediately. In terms of later recovery, there are some theories about how the brain continues to recover. There's Some controversy about some of this. More is being learned all the time. It was thought many years ago that you're born with all the brain cells you're ever going to get, that there will never be more. But that's even up in the air now. There are some newer studies that say maybe there is sprouting of the neurons that can take place. Maybe the cells in the vicinity of the damage that haven't been doing as much can pick up some slack. Maybe it's more the pathways between the various cells realign, become more efficient, and again, assume some of the functions that were lost by the damaged cells. There's a lot of cells that are in flux for a while, so we do what we can to encourage those cells to recover versus die off by oxygenation, medication, keeping the patient stable, and so on. And then rehabilitation therapy, neurorehabilitation is critical, and that really takes full advantage of the natural recovery that's occurring. We do rehab to push that recovery in the right direction, to retrain the brain and the body, so to speak. And this really focuses on building on strengths, compensating for weaknesses, and allowing the patient time as well as some rest. I'll move on to symptoms now. There are many common physical, cognitive, and other symptoms following a traumatic brain injury. Again, I'm speaking more to moderate to severe injury. In the physical category, we see a lot of fatigue and sleep difficulties after traumatic brain injury. In the outpatient setting, as you follow people with TBI for a long period of time, you learn very quickly that low energy, poor endurance, fatigue, reduced stamina, complaints of no energy, no zip, no drive are very common, almost universal. So as children are recovering from their injuries and trying to get back into school and then back into home life, I would certainly consider this. We do a lot of teaching of pacing, fatigue management, spreading out your energy over the course of the day. It's very difficult for children with moderate to severe TBI to go right back to full days of school because of this fatigue issue as much as anything else. Nighttime sleep is often impaired. Sometimes people are sleeping 20 hours a day in the beginning. So a lot of time and energy is spent on normalizing sleep-wake cycles and trying to allow the patient enough rest, but also get them some activity in kind of a paced manner. Dizziness and impaired balance are very common after a traumatic brain injury. Those tend to subside over time as physical abilities return. And I will comment that with traumatic brain injury, oftentimes the physical symptoms are not as disabling as the cognitive, behavioral, and emotional sequelae after traumatic brain injury. Many people with TBI in the moderate to severe category, within the first several months, their ability to talk and walk and speak and swallow and use the restroom returns. Weakness is fairly common on one side of the body or the other. Dysphagia means difficulty swallowing. We have some people with seizure disorders. Some of those sensory perceptual problems are not uncommon, and looking at the neuroanatomy that we reviewed a few minutes ago, you can see why that happens. Some difficulty with sexuality, sexual function, and bowel and bladder difficulties are also known to be common in this population. We spend a lot of time focusing on physical symptom management in the therapy department and with the medical rehabilitation physicians. You'll notice you see pictures. Let me comment on Frida as we're going along here. She was, as mentioned earlier, in the ICU for about a month and on the rehab unit for about a month. The last couple of pictures you've seen of her, she's obviously awake. She came out of her coma. Her family likes to tell the story that when she started waking up from being asleep and not very responsive, the first thing she did was grab her cell phone. Her first automatic behavior, a lot of people do very automatic things initially, was to do some text messaging on her cell phone. Anyway, so this is a picture of Frida on the rehabilitation unit. So she's many weeks post-injury, but you can see how much more alert she looks. All right, moving on to cognitive symptoms. Short-term memory is very commonly impaired after traumatic brain injury. Ability to learn new information and to pay attention, sustain attention, divide attention, multitask. So just commenting on those first few symptoms, you can see why return to school can certainly be challenging after traumatic brain injury. Not impossible, but challenging, which is why we spend a lot of time, both our OT and speech therapists, on cognitive rehabilitation. So there is rehab that we do for thinking changes after TBI as well as physical changes. I think most people are very familiar with, weakness on a side of the body, balance problems, difficulty swallowing, and the types of therapy that are focused on that. But there are many therapists who focus exclusively on cognitive rehabilitation, both in the inpatient and outpatient setting. Difficulty with concentration is common. Reduced speed of processing, so thinking much more slowly than normal, or not than normal, than the person's baseline, is a very common complaint. Again, likening this to the school situation, if somebody's in a fast-paced lecture and their brain is processing at a much slower speed, you can see how it might be very challenging and confusing for the student to try to keep up in a traditional classroom as their brain is still recovering. We have some difficulty with abstract thinking. Many people with TBI think more concretely. They see what's in front of them, what they can get their hands on. That makes more sense in the beginning. We have difficulty with judgment, anticipating consequences, planning and organizing. Generalization, and by that I mean taking what you learn in one setting and applying it to another. So for example, when we're trying to teach a new TBI patient how to use a planner or a notebook in therapy because we think that will help with their memory and their organization, having them take that forward on their own into the school setting and being able to apply what they've learned in therapy is challenging. This is why we try to engage the school to work with the therapist and the medical team from the beginning so that we're transferring that knowledge, and the same techniques we're using in the hospital can be used in the school setting. Same with home, trying to teach families and engage them in the rehab process so that everybody's working with the patient and cueing them and supporting them in the same way will help with carryover or generalization. Mental flexibility, that just means being able to think on your feet and not getting stuck on one solution or one way of looking at a problem. That can be challenging after TBI. And then decision-making and problem-solving. In the behavioral emotional domain, there are other common symptoms. And again, just a comment that these symptoms happen because of injury to the brain itself. If you think back to the quick neuroanatomy lesson, if the parts of the brain that control mood, our ability to stop or inhibit our behavior, to not say something socially when we know we shouldn't, a lot of those things don't work quite as well after TBI, especially early on. So we try to teach family and providers and remember ourselves that these things are happening and they're difficult for the patient to be aware of and to control. We don't like patients to be sort of punished because of the symptoms that they really can't help. The rehab strategy really tries to take those symptoms, increase awareness in the patient with the injury, and teach them how to recognize the signs and learn how to control and modify those behaviors a little bit. So we do get some people with many children and adults with disinhibited or rather impulsive behavior, kind of acting without thinking. We have we see a lot of low tolerance for frustration. And I hear patients say, little things that didn't used to bug me or upset me, they just set me off now, or I blow really quickly over something meaningless, and then I feel very guilty after it happens, but it's like their emotions are right at the surface and it's much more challenging to control or to inhibit those responses. That'll be important when it comes to planning return to school and return to home. A lot of patients with TBI get labeled as unmotivated or lazy or what have you. Really, when the front part of the brain is injured in these accidents, there can be very frequent incidences of just poor initiation, where the part of our brain that helps us jumpstart behavior and thinking and communication is kind of broken, and it's more difficult for them to initiate. So there are certain strategies you can use to help students with that particular issue. We get a little more inconsistent follow-through. I mentioned impaired self-awareness. This is very common after moderate to severe traumatic brain injury. Many patients will say, I don't know what all the fuss is about. I'm just fine. Let me go to school. Let me drive. Let me go to work. I don't see anything wrong. This is very different than denial. Oftentimes it comes across as looking like the patient is denying they have trouble, but again, it's that part of the brain that helps us understand ourselves, take a picture of ourselves, understand our own strengths and weaknesses. It just doesn't work very well in early recovery. So that's something we work on in therapy. Perseveration is somewhat common, where people just get stuck on an idea or a behavior that they repeat over and over again. Labile emotions, which means up and down, kind of moody, or flat affect. So affect is sort of emotional presentation. So some people will look very flat and kind of depressed and have no facial expressions. Either one of those we do see. Depression and anxiety, these are not early symptoms after moderate to severe TBI. Usually the person is confused, just starting to put everything together, but it is a common later symptom as the person's brain recovers and they start understanding something bad has happened, I'm not the same, I can't go to school. We really do try to keep an eye on mood disorders and offer the students some support as they're recovering from their injury. And then less effective social and communication skills are also common. We spend a lot of time on family education and support, and again, we try to also really support school staff, understanding that these are probably the two places an average child or teenager with TBI spends most of their time, is with their family and friends and in the school setting. So in terms of family education and support, we spend a lot of time just reassuring families on what's so-called normal after traumatic brain injury. What are we looking for? What happens in the various stages of recovery? Most people don't know. They haven't been exposed to this type of injury. And that's important to really help them understand that agitation in the early stages of recovery from TBI is actually desirable. People tend to have a better outcome when they wake up sooner and they're agitated versus sleeping for months on end. So if you can kind of reframe and reassure about the normal stages of recovery, that I know this isn't how the patient normally acts, but in our world and in recovery patterns, this is actually a good thing. Families, coaches, teachers, friends, it's much easier to understand and to focus on physical injuries than cognitive or behavioral changes in a person. For example, Frida, a track star, when I went to her school to do an assembly with her father, her traumatic brain injury was actually her more concerning injury to us at Mayo Clinic, but the questions from the audience and from her teachers, obviously her coaches, was what about her broken back? Because she had broken her spinal column in several places and had metal rods implanted in her back. So that makes sense to me, actually, that they can see these physical injuries. These are things you understand, a broken back. Not a lot of people understand traumatic brain injury. And I think it's fine to answer those questions and to focus on those physical injuries. At some point in time, we will ease families and staff and coaches and everybody into now let's talk about the traumatic brain injury and what are the nuances of that, what kind of concerns do we have with that type of injury. In TBI recovery, we tend to get big stuff happening first. I mentioned earlier that, walking and talking and swallowing and some of those things tend to happen in the first several months. The fine-tuning phase of recovery really goes on for months and years. So the higher level cognitive functions, social skills, some of the more sophisticated speech and language functions, those things just take longer. So we try to tee up families and people in the patient's life that recovery is going to go on for a long time, and that might seem like bad news. We try to frame it that this is actually good news, that you're on month 3, which seems like a long time to you, but in the grand scheme of things, this person has months and months to continue to fine-tune and get better, and there's no reason to think someone will just stop recovering. We expect gradual improvements over months to years. A long time ago, people were told, you have a year to get better, and if you're not all recovered in 1 year, too bad for you. The recovery for TBI now is open-ended. We see people get better for years after their injury. Inconsistency during TBI recovery is very, very common. It's sort of part of the game. People have good days and bad days. Their symptoms wax and wane a little bit, but as long as you reassure everyone that that's part of the pattern of recovery, I think that's a helpful thing to do. Again, what are we looking for during the stages of recovery? We invite school and families and whoever's involved in the child and student's life to come to therapy, watch the strategies, learn the techniques that we're using to interact with patients. We always try to support our families and let them cope as best they can. This is a tragic injury, and families really sometimes get lost in the shuffle. We also try to remind everybody in the child's life that progress is still progress and we're celebrating. So sometimes it'll seem slow and so minute that you think, oh, it's plateaued, it's stopped, they're never going to get better. But you have to keep an eye out for those little changes, because after the big stuff happens, there tend to be littler things that are harder to detect or take longer. We try to encourage everyone that progress is still progress and it's definitely worth celebrating. One of the best inventions ever for people who have these catastrophic type injuries is Caring Bridge or Care Pages, which is sort of the Mayo Clinic version of Caring Bridge. But these are wonderful websites where you can put the patient's story, pictures up on a website, and families can post information about the patient, how they're progressing. Common information, accurate information is shared with everybody. It's a place where if the family needs something done, we need the lawn mowed this week, people can sign up to help. And then friends of the child, the student, can post their thoughts. They can follow along and really share in the experience with the patient and family. Most patients down the road when they're recovered really appreciate the journal that this turns into for them. The recovery process takes time. There are common stages. People kind of move along at their own pace. There's no identified way at this point in time to make recovery from moderate to severe TBI hurry up, go faster. The good news is a lot of times the people that are going slowly at the beginning are the ones that are going quickly. As things march forward, almost everybody does better than you think they're going to do based on some of the early predictions. I'll talk a little bit about the TBI model system in a little bit here, looking at outcomes and data. It is somewhat challenging to predict with 100% accuracy the outcome of every patient that we see. We look at things like, how severe was the initial injury, what did their CT look like, how old are they, how many other injuries did they have, how long they were in a coma, but it is still challenging to do that precisely. Some of the things we look at I mentioned here. Pre-injury status, for example, if somebody had pre-injury learning disabilities, psychosocial difficulties, depression, anxiety disorders, chemical dependency, abuse or use, well, sometimes those folks have a more difficult, prolonged, or less complete recovery than someone who doesn't have a very complex pre-morbid or pre-injury history background. Family support is important. We definitely look at the initial severity of injury. I mentioned earlier that it's not a precise science, but that is one of the things to be considered. It seems to be that one of the things that looks a little bit more accurate is how long is someone confused. We can kind of use that to predict outcome in some sense. And then how much recovery has the person made in terms of cognitive physical function status when they leave the rehab unit. So in those early weeks to months, how are they looking by the time they leave? Sometimes that correlates a little bit better with outcome a year later, 2 years later, than their original CT scan. So that's something we take a look at. I will ask for your help in using education to dispel the myths of traumatic brain injury. So there are a lot of myths surrounding TBI. A lot of this is perpetrated in the media. So for example, in the average movie or soap opera, when somebody goes into a coma or they're in a coma because of some horrible accident, in the movies they really show a patient just sitting up one day and they look great, their hair is splayed across a pillow, they don't have these scars and trachs in their neck region, they're not on ventilators, they just look like they're sleeping, and then they sit up one day and all is well. It's like coma ends in one day. Well, that's not how coma ends. It's a gradual process for almost every patient I've ever seen in 27 years. And so educating people that this slow process of waking up and stops and start is reality. It's not like it is in the movies. Amnesia, I mentioned earlier, it's almost unheard of for someone with TBI to have true amnesia, that is forgetting their whole life, everything they've ever learned or known. Most people have post-traumatic amnesia or confusion for a while when they first come around. Another myth is that you can look at a CT scan and a Glasgow Coma score and that tells the whole story. We've already talked about that is not the case. Something I call the regarding Henry syndrome. If there are any older listeners out there, this is a movie from a couple of decades ago, I believe. It had Harrison Ford in it, and he was either a physician or a lawyer, and he had a traumatic brain injury, and he was sort of an intense man, even a bit of a jerk before the injury, and then he had a TBI, and then he was wonderful. He was just so fabulous and kind and warm. It almost made you want to go get a TBI just so you could be so wonderful. Well, there's not a lot of truth to that. Usually people, their underlying personality qualities and the type of person they are tends to get more enhanced by a TBI versus them doing a complete flip-flop. Now, there are a lot of behavior changes in the early recovery that we see, but in general, many people become more like they were versus have a complete turnover in their personality, though we do see that once in a while. We talked about the initial injury severity, all or none outcomes. We have a lot of less experienced medical providers who will tell families and patients, oh, you had a mild traumatic brain injury, you're going to be 100% fine, you don't need any care or follow-up. Or you've had a severe injury, you should go to a nursing home, you're never going to get better. That kind of prediction and those kind of statements are really devastating for families because oftentimes they don't turn out to be true. So we really try to guard against all or none outcomes. Time will tell. We're going to proceed with optimism. Sometimes families get a bit of grief from providers and those around them saying the family doesn't get it, this is a bad injury, little Michael's never going to be quite the same again. Well, families have a lot to deal with, and there's no sense in pushing reality when we also don't know how things are going to turn out over time. So I'm very protective of families and have learned to really advocate for families that, they're doing the best they can. If they want to focus on a broken leg before a concussion or a head injury, we'll get around to that in good time. Patients get accused of being in denial and not motivated for the reasons I discussed earlier. That's really damage to the frontal lobe versus those true conditions. So somebody's recovering. They've had this moderate to severe injury. What do? Well, we work hard in therapy, and usually when people leave the hospital, we try to still keep them in therapy a couple, 2-3 times a week, and that will diminish after school starts. Many students will turn over to a school-based therapy team after they return to the school setting. We spend a lot of time on teaching and practicing study skills and compensation skills. So we're trying to teach someone, if your memory is not working normally, how are you going to learn and remember information? There's a lot of things they can learn in therapy, but to acquire those new compensation strategies or techniques takes a lot of time and practice. So this is what the student is working on in therapy. Anything we can do to promote self-awareness. A lot of students with TBI will say, I spend more time on my homework than anybody. I work at it hours and hours and hours. So that is true. Sometimes there's just an efficiency in the approach the person is using. So we try to work on some strategies so that they're working smarter, not harder. They're more efficient during the time they're studying versus spending hours and hours and hours rereading the same information and not feeling like they're getting anywhere. A lot of flexibility, creativity, and patience is used in the therapy process. This is a young adult or a child that should be included in the process of rehabilitation and setting goals. What's important to the patient and their family should drive the process, as well as some of the expectations from the rehab side in the school setting. We try to offer choices. Many patients have lost all control of their lives with this injury and recovery. Active problem solving is important. Again, educating and involving families. We allow a lot of supported risk-taking. Because of reduced awareness, a lot of people will say, why can't I do this? Why can't I do this? Well, you know what? Maybe we should let you give it a try. We're not sure it's going to go quite as well as you'd like it to, but we can allow you to try that as long as it's supported risk-taking and there's not dire consequences on the other side of it. So sometimes you will definitely see us letting patients try things that we're not quite sure they're ready for, but that's part of the learning process. Frida, just some comments on someone like Frida. As you can see her here, this is I'm going to say less than a year after her injury, and she's on a trip with her family in this particular picture. But and I use Frida as a case study not because she is a miracle. She made an amazing recovery, but we see a lot of miracles like Frida. Her outcome with it looking so bad and difficult on the front end and then getting better over time, we see all the time here. So a lot of the things we've been talking about, education, early intervention, rehab and academic goals being combined or in alignment, a lot of practice and repetition, a lot of therapy, gradually reintroducing her to her usual responsibilities, school, following her, keeping the door open so that she and her family can stay part of the medical rehab and then be really engaged in the school process. I'm going to skip over this one. This is a kind of a repetition of the last one. This is just a quick slide. I think you're going to be having other talks coming up in the future weeks about transitioning to school and some of the accommodations and such. But this is just a list of some of the things that we use frequently for students going back to work after traumatic brain injury. We rarely start anyone back in full-time school. We almost always start in an hour or two a day and build up from there. A lot of accommodations. Sometimes we try to get credit for therapy, tests in quiet areas, supported study halls, brain breaks, kind of mini breaks throughout the day involving the school social worker and psychologist. So I just wanted to put a couple of those out there with the understanding you'll get much more education on that in a future session.
And I just want to give you a quick update. We've got about 45 seconds before our webinar shuts down. So.
Oh, and I don't have a clock in here, so okay.
That's okay. Sorry.
No problem. I will go into mild traumatic brain injury quickly. So mild TBI is actually much more common than severe. Many people with mild actually do much better than you think they're going to do. However, people with mild traumatic brain injury also need education, and they need some contact communication between the hospital and the school. There are some very good resources and information and educational products about pediatric traumatic brain injury and mild TBI. Most people with mild TBI are really going to recover. I'm going to get to a slide with some resources here. Really going to recover very well within a few days up into the 4 to 6 week range. Some people take longer than that, but it's definitely worth following individuals, but I would proceed with optimism. The expectation is that most people with mild TBI or concussion really are going to do well, but they need education, follow-up, support. Many need to be returned back to school as gradually as well because of fatigue, dizziness, headaches, concentration problems, and so forth. Some resources here, and I'm sure we're out of time. So here's some information about the mild traumatic brain injury. If you go to the CDC website and punch in traumatic brain injury, excellent resources for coaches, school nurses, parents, teachers. There are toolkits that can be ordered free of charge from the CDC with great information on concussion level patients. Transition to school. Just a final picture of Frida. This is Frida 1 year after her accident. Obviously, she was doing very well. She ended up going to Purdue University, graduating from high school, going into Purdue, and she's currently a junior, I think, at Purdue, and she's doing well. Traumatic brain injury model systems. This is just the research that's done around the country on traumatic brain injury. And you can also Google TBI model systems and find information about this. So what we've learned about TBI is that people really do tend to get better after traumatic brain injury, so it's perfectly fine to have optimism and hope. And I think I will, at that point, sign off because I think we're out of time. Thank you.
I want to thank everybody for participating on the webinar today, and we will have some follow-up with you. So thanks again, and have a great afternoon, and we hope you join us for our future webinars.